We're back, and now we're going to go over the reported bile duct injuries. And the class 1 injuries, and this is remember the Stewart-Way classification, 7% of the 252 injuries were class 1s. And most of the time, there was an incision in the biliary tree, and there was incomplete transection of the common bile duct. With the class 1s, remember there's no loss of duct. And this is why I mentioned opening up that Hartman's pouch common bile duct angle. The common bile duct was mistaken for the sixth duct 72% of the time and subsequently recognized by cholangiography. And then there was an incision in the cystic duct that was extended into the common bile duct 28% of the time. So these are some of the nuances associated with these class 1 injuries. Now let's go to the class 2 injuries, which made up 22% of the injuries. And these particular injuries were lateral damage to the common hepatic duct with or without a stricture or fistula. And usually that's that Pac-Man one. Remember that class 2, I call it the Pac-Man injury. It involves the common hepatic duct and secondary to clips and or cautery. And then you can get stricture formation with or without a bowel leak. Now, class 3s. And this is a particular injury that we had in the video that you saw. The class 3s occurred 61% of the time. And the 3A, which is 68% of this distribution, had a remnant of the common hepatic duct remaining. A moment, let me pull this down. Class 3B had the common hepatic duct excised at the bifurcation. Now see, to me, what Larry was doing with this one is basically, Jesse, inserting the bismuth. You see what I'm saying? Then 2C, 10% were they had the actual common hepatic bifurcation excised. And 3D, 4% was above the first bifurcation of at least one of the lobar ducts. So you see what's happened with the Stewart-Way. They injected the bismuth classification E1 through E5 into their class 3 injuries, which were the majority of the injuries. Now, some interesting findings with the class 3 injuries. In 31 cases, or 20%, the proximal hepatic duct was clipped. In 122 of the cases, the proximal hepatic duct was left open, and the injury we had was technically open because it was partially clipped. And here is something you have to understand too. 27% of the class 3 injuries had a right hepatic artery injury. And I was wondering, Jesse, could you explain to the uninitiated out there why it's important to recognize the right hepatic artery injury with these, and what are the clinical ramifications of this?
No, it's incredibly important. I can talk about it now. I actually have a couple slides on it as well, because I think the concept of vasculobiliary injuries associated with bile duct injuries is incredibly important, not talked about enough. And you highlight this well, that this isn't the only study that has shown a huge, high rate. I think this number would surprise a lot of people if they weren't aware of it. And, studies show 1/4 to 1/3 of patients with major bile duct injuries end up having an associated vascular injury. And that causes problems for their, certainly their repair, their recovery. They can develop ischemia. This can lead to further complications as they're recovering from this. It can cause a whole, host of things. And I suspect, to be honest with you, that this number is higher because this is only in the known complex bile duct injury pool of patients, right? But there are probably patients who end up getting a cholecystectomy without a major ductal injury, but have a clipping of maybe even their right hepatic artery. And I've seen many patients who I've looked at their scan and for something else, and they have a very atrophied right lobe of the liver. And they have a lot of clips in that, along the cystic plate, and they've had their gallbladder out before. And, I even money bet that patient had at the very least a stricture from cautery or from a clip that was too close. And oftentimes because the liver blood supply as a whole is so robust, because it's unique, right? It has not only arterial blood supply, but it has portal blood supply, that oftentimes you can, I hate to say it, but get away with it. And the patient will remain relatively asymptomatic, even with potentially a major, significant arterial injury. So I bet this number is even higher, and some people, it goes unnoticed.
Well, that was one of the teaching pearls I wanted to bring out, and I was really excited to have you here. And I don't want to steal your thunder. There's so many iconic waypoints here that just beg for your interjection. Thank you so much. And guys, that's why you need to know all of these things out there. You need to know these things because, everything that we do has ramifications, and you need to know the expanse of this. And this helps you to always stay forever vigilant, like Adrian was alluding to. You always must be vigilant.
I do want to ask a quick question of Jesse because this is the time to ask it.
Yeah.
But I've always thought when we do hepaticojejunostomy or specifically a colodocojejunostomy with a transected common bile duct, theoretically, the supply to that common bile duct, the blood supply, is gone. It comes from underneath. It comes at the 3 and 9.
I just went over there. Jesse, you comment on this. The blessing, the reason we get away with it, and Jesse, you just talked about,
because of the portal
branch of the gastroduodenal coming up, but also you have right hepatic artery coming down at the 9 and 3 o'clock position. Is that true? I just went.
Absolutely, that's true. And so, when you have a bile duct injury, you're relying oftentimes much more on that right hepatic artery as the superior blood supply. And I'll get into this when I talk about repair, because, that usually takes off right at the bifurcation and starts giving the arterial supply at the right hepatic artery, right when it usually crosses underneath the bifurcation of the bile duct. And so that's oftentimes where it's the most robust of blood supply. And then it travels down exactly like Dr. Rosser said at that, 3 and 9 o'clock position. But it's both from above and below. And, hopefully they only have part of the blood supply that has been injured. But in cases where they have a vascular biliary injury, they may have all of or a significant amount of both the inferior and superior blood supply to the bile duct. If the right hepatic artery has been injured as well, then you may be really in a position where you're worried about ischemia to the bile duct.
And I want to I love connecting dots. I want the audience to go back to the video of the common bile duct injury. And there is a chapter where the common bile duct, which is a class 3, totally excised, and you can see the spurting arterial blood supply from the proximal hepatic duct. You actually see that anatomy and how that blood supply, if it's uninterrupted from above, how it comes down. Thank you so much, guys. Now let's go into class 4's injuries, and it's 10%. And you have damage. This is a very high injury. And I tell you, Jesse probably has been taking out liver parenchyma just to get to this injury, and he'll talk about this later. But this is a very high injury. We used to not see injuries like this in the old days as aggressive as this. But you have damage to the right hepatic duct, and you can get damage to, there's a right segmental hepatic duct also. And absolutely, like Jesse alluded to, 60% of these injuries will have a hepatic artery injury. 60% will have this injury. So these are the Stewart-Weight classifications of the 252. The pearl to remember is that the most prominent one is the class 3 injuries. And remember that those injuries are the ones associated with the 4 bismuth classifications on that. Now, I want to note some anatomic variations that were picked up in the operative summaries. 88 cases out of the 252 had a report of extratubular structures. Now, to me, when you can have a lot of variation in the biliary tree, more than you would think. But when you start reporting, these UFOs, okay, of extratubular structures, that probably means you're in trouble. And 88 of these cases reported these extra, quote unquote, tubular structures. There were additional vascular and hepatic structures that were called out in 33 cases. A short cystic duct, which I'm telling you right now can happen, but also you may have been dealing with a common bile duct, was reported in 8 cases. A wide cystic duct, since none of these had common bile duct stones, probably those reported, they happen to be the common bile duct. Remember, Jesse talked about all these clips in an area. When you see what we call clip clutter, that is a bad situation going on there. It's almost pathognomonic for some type of injury. And then there were 36 cases that said, well, we didn't have any extratubular structures. And what I wanted to do is, these are 124 noted anatomical variations from the operative reports. Now, they did a great job here of having the distribution. We talked about most of this, the class 1s through the 4s. I wanted you to pay attention to where the right hepatic artery injury is associated. You can see there was a total, as Jesse alluded to, 67 arterial injuries in this group. And I just want you to, the other common bile duct, bifurcation, hepatic ducts, et cetera, have been already summarized. But I want you to see the point that Jesse was making, that you have a large number of vascular injuries. Now, let's look at some interesting findings with this cohort. 188 or 75%, the procedure was completed without recognition of the injury. Now, let that sink in. 75% of the time, people did not recognize the injury. Now, the injury we had before in the video, the injury was recognized and the appropriate things done, which Jesse would talk about. But that's why we talk about these classifications. That's why we go over the anatomy, so you can be able to understand what can happen. And if you know what can happen, you can do a great job of trying to prevent it from happening. 57 or 22%, the operative report revealed nothing unusual. Nothing. Now, what is that telling you? Your perception, you must keep your head on a swivel, because your perception of what's going on should be always questioned. 22% of the time, the surgeon had such tunnel vision, they didn't report anything unusual. Now, 13% of the cases were converted to open, secondary to difficulty of exposure. But this is even more concerning. Only 18% of the injuries were discovered in the open setting. That means you open the patient and you still didn't recognize it. And Jesse, I like your comment for both of you all on this. I believe we have a challenge, not only laparoscopically executing these procedures, but the art of open cholecystectomy has been lost. And the anatomical vantage points from the open setting, similar to what happened with the anatomical vantage point of the inguinal hernias, when you look at from the backside, we've lost that. We've lost that ability. What do you think, guys?
I agree. I mean, an open cholecystectomy can be a challenging procedure. Absolutely. And it can especially be a challenging procedure when there's a lot of inflammation, when the patient's anatomy is not helping you out, when they have a very low costal margin, when you haven't, if you're a trainee, if you're not that far out of residency, and maybe certainly I would say that the average trainee graduating now has less open experience than 30 years ago. And that's not a bad thing. I mean, they have more minimally invasive experience, but I would certainly say that the vast majority of open experience they have are probably midline laparotomies. And so, whereas 30 years ago, there was probably a lot more variability of the different types of incisions and different types of exposures. And then, so now if not only are you doing a procedure that you don't have as much experience with, but the procedure itself, but just the exposure sometimes can be a challenge.
Most of them don't know how to use packing for the exposure. That's a lost art form that we had to master. I'm glad you brought that point up.
And it can really be a challenge. And so, in some cases, and some of the residents I talk to now, I think that it kind of depends on their comfort level and their experience, and certainly the case itself. But I think, some graduates are going to have better skills staying laparoscopic and maybe doing a partial cholecystectomy, or maybe even just putting a drain in and living to fight another day. I think the mistake that people make, and my main take home point a lot of times, is you don't always have to take the gallbladder out, especially when it's, you're risking injury to the patient. Almost every bile duct injury that is sent to me or that I, get called in for is usually, well, don't worry, I got the gallbladder out, but there's this big hole in the bile duct. But, I would much rather have them say there's a very small hole and the gallbladder is still there. We can take care of the gallbladder. We can take care of that. It's the bile duct injury that's a bigger deal.
And guys, forgive me if I'm bringing out more nuances, but it's these nuances that are the difference between being a good surgeon and a put knocker. All right. I mean, it's knowledge of these things to help you to master your craft. And in fact, that's where I hope one day, there'll be a use for old fogies like me with technology to help oversee the nuances of the mastery of surgery. See, everybody thinks, well, just observe and it'll be transferred. No. It takes too many cases and we don't have enough time. I think what I'm trying to do, Adrian, is actually have, a cadre of assets that educates you on the little things. For instance, here's a great example. How to fold a pack to have effective packing of the abdomen or effective packing through a cochlear incision of a cholecystectomy. Who gives you details on that? How do you find out about that? And that's something that, Adrian, I'm concentrating on, because coaching is going to become very important to spread this knowledge that has been lost. What do you think?
That's something, Butch, that we're actually adding to it gives me a chance to plug our National Surgery video library, where we already have a multitude of videos on not the herangiomas, the things that you see on the society video archives, but on how things are supposed to go. Here's a good gallbladder. Here's a nice right hemicolectomy. Here's a gastric bypass the way it's supposed to go. And we actually are working on a video of laparoscopic skills. exactly for things like a pack. But I do want to echo what Jesse said. Yes, the art of open cholecystectomy is fading away, but most importantly, the art of exposure, that I take my time and slow everything down and tell the resident or the fellow that's with me, this is all about exposure. And we get the book Walter in there, and I teach him almost like a trauma exposure, where you get a wet towel and you slowly unroll it to push the colon down the antrum medially, and doing so without causing additional damage to those organs that have to be retracted, but in a way that is safe for the patient. But it's all about exposure.
And this could be a lost art. So, and guys, thank you. I hope, and forgive me, Dan, if this isn't how you envision this, but there's just certain things that just jump out.
This is wonderful. This is exactly what we need, because this is the portion of our repertoire that doesn't have structured lectures, but things that you really need to know to be a safe practicing surgeon. This is exactly what we need, Butch.
Well, here's some more interesting facts from that paper as far as common bile duct injury identification is concerned. Since we've documented that most of these are not even recognized. And let me tell you why that's important. You don't recognize, I can tell you, and Jesse will be telling you later, you want to get these things fresh, not when you got sepsis in the abdomen for 2 weeks or so and this sort of thing. You want immediate recognition if possible. Now, the common bile duct injuries, 17 of these were recognized by a cholangiogram, even though we had most of them unrecognized. And let's look at what cholangiograms can do. Now, 7 of them were recognized by cholangiograms. 7 was from inspection of the removed gallbladder. And I'm going to tell you right now, if that person inspected that gallbladder, I believe they strongly knew Jesse something was wrong. All right. Now, 6 of the class 1s were identified when they saw what? Bile leaking from the common bile duct. And 26 were via operative identification of the injured hepatic ducts. But only 15 injuries were recognized early enough to limit the injury. And see, that's where the pundits and the people who prescribe routine, they say, yeah, you can have a common bile duct injury from getting a cholangiogram, which I'm going to show you a little later, but you can limit the injury. And Jesse probably will be talking about that later. Now, the impact of cholangiograms, 60 of them were done routinely. 43 injuries were discovered. A third of them were missed. And this is because of the issue I talked about earlier, misinterpretation of the cholangiogram, or not really being facile with reading cholangiograms. 9% were correctly interpreted, were incorrectly interpreted when the proximal duct did not opacify. Everybody looks down, right, Jesse? Not many people look up. and you'll see an example of that later. And this is the other thing. We don't read these things as well, because 2 of the 9 divided the common bile duct before the films were interpreted. They didn't wait on the interpretation. They were so convinced. And 28 of these cholangiograms, many of them judged normal. There was no opacification of the proximal biliary tree, and they got away with it. You can actually see where the common bile duct was narrowed at the entrance of some of these. 6 were thought to be normal, but the catheter was in the right hepatic duct. 18 were done after the injury was suspected. And in 17 of the 18, they saw the injury. Now, what I want to do here is just show you some of the examples of the misinterpretation. So, look at this particular cholangiogram, which was interpreted as being normal. However, the catheter is in the right hepatic duct, right here. So you see the distal duct, you see the left, you see the right, but you injured the right to actually get your cholangiogram done, and then it was interpreted as being normal. This went on to have clips placed to close the hole, and it led to a class 2 or a Pac-Man injury. Here's another example. Take a look at this one. Oh, proximal ducts, you can see them, right? But look at this. There's a narrowing here. This was not placed in the cystic duct. The common duct was mistaken for the cystic duct, and you have a narrowing. Look at this. I call it the Betty Boop sign with this narrow waist right here. That's because it is actually in the common bile duct instead of the cystic duct. See, these are all errors that can happen by attending surgeons. Now, this is a classic where this was interpreted as being normal, but where are the proximal ducts? Proximal ducts are nowhere to be seen. So in summary, because as Adrian mentioned, this could be like surveying the video review of train wrecks, but it's not meant to shock. It's meant to educate you and prepare. Because the fact of the matter is there is an unacceptable incidence of common bile duct injuries. These injuries are much more complex than seen in the open era. Most are not recognized at the time of the procedure. Routine cholangiograms may help to limit injuries, but it's not a panacea. And there is definitely a cognitive and procedural execution gap that must be eliminated. We must concentrate more on the granulations of the details for success. That's the problem with all surgical procedural literature. They leave gaps in the details. And it's all about the details in what to see, how to see it, and when it's not seen, how to mature the anatomic landscape so it is seen. And that means we have to go beyond we have to get countermeasures beyond the critical view. I'm just telling you right now, we have to add more meat to the critical view framework so people really can be prepared to perform these procedures with the lowest incidence of injuries as possible.